our esteemed chairpersons, Professor Munir Khan, Professor Ilyas Sharma, Dr. Imran Mir. Sir, kindly come on the dais and chair the session. Will be live telecasting two cases. One will be from OT3 and second will be from OT2. From OT3, we have honor to introduce Professor Syed Sajad Nazir. Sir will be doing RIRS on a patient having nephrolithiasis. Sir, you are live to us.
Okay.
With this, we start the Valley Eurocon.
Good morning, everybody. Hello?
Yes, sir. Sir, you are audible.
Okay, yeah, fine. So, we'll be starting with the first case.
Yes, sir.
And I will be demonstrating RIRS.
Yes, sir.
And the case details will be just showing to you.
Okay, sir.
Tell me.
So, we are officially introducing Professor Syed Sajad Nazir.
Yes, correct.
He is professor and head Department of Urology. He is a member of National Board of Examination. His areas of interest are RIRS, uro-oncology, especially renal mass surgery, bladder cancer surgery, laparoscopic uro-oncology, reconstructive surgery, and renal transplantation. He has significant number of publications in national and international reputed journals. Sir, you are live. You
Okay.
can demonstrate the case.
Is there any picture of NCCT?
Just,
So that we
just,
can see the stone.
would you just give me the details of the patient?
Sir, is operating on a female patient. She is a 22-year-old female with no medical comorbidity. He had presented to us with the right flank pain from last 6 years on and off. And she was evaluated in our OPD. Her baseline investigation was significantly normal. Her ultrasound was showing right-sided 13 mm calculus in the mid-pole, no hydronephrosis. Her CT urograph was showing 13 into 9 mm calculus in the mid-pole with a Hounsfield value of 1150. So this patient has been planned for RIRS. Sir, you are live. You can.
Okay. So
we are proceeding with our first patient. That patient is a case of renal stone disease presented to us with a chief complaint of pain over right flank since 1 year on and off.
Please speak
She came to our OPD and evaluated. Her routine investigations were creatinine was around 8.85.
Sir, we have already enumerated the details.
And her
of patient.
hemoglobin was around 7. Coagulation profile PT around 13.3 and 1.06 was her INR and her urine culture was sterile.
okay. So this patient has been stented. Hello.
On her USC abdomen, her right kidney was having 12 mm calcium stack with some focal characteristics. Her left kidney with
Now,
few calculi largest around 6 mm.
what we do now, we'll do the cystoscopy and remove the stent first.
Her CT has been done. Our CT was showing in right kidney there was a hyperdense calculus of 13 into 7 mm at inferior pole with CT attenuation of 1213 HU.
So this is the left part of
She
this.
is now planned for
You see the video?
right-sided RIRS and we will be now proceeding to OT3 and the case will be done by our Professor Dr. Syed Sajad Nazir sir.
Hello.
Yes, sir.
Yes,
Sir,
we can hear you.
Yeah. So this is the stent on the right side. So we'll be just removing it.
We can't see the KUB with the
Sir,
stent
your screen
and
is
the
not-
stone.
No. Just
Is there a KUB with the stent and the stone? If you
Yes, sir.
have it available, just show us.
I don't. So the stent is. We took out the stent. This is urethoscope.
Yeah, we have seen it. Yeah, we can see that. It's in the pelvis only, this stone, okay?
Yeah.
Okay, fine.
Urethoscope.
Dr. Ghulam Nabi has joined us.
Yeah,
And
it's an
Dr.
honor.
Dogra is also.
Sir, we welcome you.
Dr. Ghulam Nabi is a son of the soil. And he's these days in UK. Has a very high position. right? Very difficult for him to take his time off and come here. We are thankful for him.
So welcome to you.
So
Yeah,
now-
we can go with the case, yes.
So now, what we do always, once we remove the stent, we see the ureter and see how it is.
Ureteric orifice.
Yeah, so all the time, we do a semi-rigid ureteroscopy in these patients.
Okay.
And see the status of the ureter. So this is a nicely dilated ureter.
No, we can't see the endo picture. Show us the endo picture. We'll see for ourselves.
And
Yeah, we can see it now. Good.
so this is a PUJ, okay?
Yeah.
So this is a PUJ, this is a well dilated ureter. So this is the advantage of having a pre-stent.
Right.
And we usually do, okay, put the guide right now.
Dr. Sajad,
Yes, sir.
what is your experience in a pelvic stone, especially in a female, if you take a rigid stone, ureteroscope up into the pelvis and try to fragment majority of the stone, do you do that? Or
No,
you
no.
always go with flexible?
No, I always go with the flexible.
Okay.
Because what is happening, this is a PUJ. So this is a fixed. The PUJ is a fixed and you have another fixation which is at a UVJ. So if anything wrong, if you push or you go to the right and left deviation of the ureteroscope, your ureter will be avulsed.
So do you advise rigid ureteroscopy of the ureter before
Yes.
introducing your access sheath?
Yes, definitely. Because what is happening, even you put a stent sometimes, the patient, the ureter is so tight that you will be fastly taken that the ureter might be dilated. And then you may see the condition of the ureter. And after that, once we complete the procedure, we also come out after the sheath and to see is there any damage or not. So you can know beforehand whether the ureter was damaged pre or at the post.
Okay, Dr. Sajad.
And sometimes a stone also was after placing of the stent. A small stone may also come on the side of the stent which you not see on the day of surgery. And if it's-
And now after CR, how? Fixed on the CR.
which make is the Siam?
Yeah, this is a Scanway, sir. Scanway hands this CR. So
And who is the anesthetist?
anesthetist is Professor Ruxana's team, and then you have here Dr. Arshi
Dr. Ashok.
and Dr. Humaira.
Okay, and we can't see Dr. Ruxana there?
No, she's here.
Okay.
She's in the other OT.
Okay.
So this is this X-ray. So we have put the guide wire. So you see the guide wire, sir?
Yeah, beautiful.
So,
We can see
what
it.
we are using this time, I'm using an ester SS sheath. This ester SS sheath comes with a suction.
Yeah, show the suction channel.
So this is a suction
Kindly
channel.
zoom in on the Excel sheet,
Yeah.
please. Yeah.
So this is an SS sheath from ester. It is 10 by 12. And
Ester?
here you can connect from here. Now you.
Right.
So this is an
There is a separate channel for the
Yeah, yeah.
suction or the same channel?
no, sir, separate. Because
Separate
there's this is an here is an this
Just
adapter.
zoom in. We can't
Adapter.
see.
So this is an adapter here.
Okay.
Which has the for this guide wire as
Guide
well
wire.
as for the suction. So this is the attachment.
Okay.
So you connect it with this with the bottle, and then from the bottle you connect it to the your own OT section.
Okay.
Very nice.
So whatever is the fragments, so they will come on with that.
Yeah.
So this is the ester which I are using now here. Got this disconnect.
Very nice.
So now I will put the SS sheath under the CRM guidance. Okay. Yeah.
I'll request Professor
Dr. Jilani Saab has joined in.
join the jail for
Welcome,
thoughts.
Dr. Jilani Saab.
Huh? Okay. Bon.
Aye, sir. Aye, sir.
So this is the SS sheath going on, sir. You can see.
Yeah, we can see that beautifully. It's just sliding in.
Yeah, it's just going easily. Wonderful.
It's you every time use a new Excel sheet or?
Yeah. So we use all SS sheath single use.
Oh,
Because the luxury we have golden card.
very good.
Because these patients are all under golden card and they are free. So we can use at least, we are using each stent is an single use, guide wire is a single use, SS sheath is a single use and basket is a single use.
Great.
So we have the luxury of having this one. So I will be using this digital scope Flexus 2 from Carl Stores. Usually I am using VR3 from Olympus. So now this one, because the system is here, which is connected here. So after putting the SS sheath and removing the guide wire, so we will be connecting it to the flexible uteroscope, and then we will go. So this has same.
So you're using the stones here?
Yeah, I am using a store system. Yeah.
Flexus 2.
Flexus 2.
What is the diameter?
Flexus C.
Flexus C, okay.
8.4.
8.5.
8.5 diameter, and now you can see the vision. So we are doing it on the store system which is used here is then 4K.
Okay.
So this is a 4K system. So I am going into the SS sheet.
Very high resolution.
Yeah.
Stones also has a disposable.
Yes, sir. So these are the things what we see once we have that patient the stents. So you just keep it for 3 or 4 minutes till there's water goes on, and then you will see the good vision. So this is a clot which is because of the previous stent. So this is a PUJ area. So this is a PUJ. Now I'm going into the kidney. So now I will be. See, this is a stone. So this is a stone which is in the middle calyx. These are the inferior calyx. Are you seeing, sir?
Yes, you see the calyx.
So this is the stone here.
Also very well.
Yeah, this is the middle calyx.
This is 1100 ounce units.
Yeah,
right?
so these are the papilla. These are the Rundus plaque.
Yeah,
you can see it
beautifully
here.
seen, beautifully seen.
And this is the upper calyx.
Right.
So there are these plaques are there always. So these are the patients what we have seen for a long period of time because doing so many RIRS. These patients usually form stone in long run. So this is the upper calyx.
Do you do something for these renal plaques also? Or you
Nothing. Just wait and watch.
Okay.
So the vision is absolutely fine.
Yeah.
So this is the upper calyx. These are the middle calyxes. And this is the stone here. And here, this is the lower calyx. Fine.
May I add a small comment for the sake of the audiences if they are
Yes, sir.
interested, how this RIRS got evolved. When we were attacking the upper tract stones by minimally accessible surgery, it was the era of PCNL, then came the mini PCNL, then came the ultra PCNL and so on and so forth. But from day one, the nightmare of a PCNL surgeon always was the unpredictable bleeding. That would ultimately, mean either an angioembolization or even sometimes, very rarely, even a nephrectomy in desperate situations and so on and so forth.
So here.
So, only 1 minute, Dr. Sajad.
Okay, sir.
So, this RIRS is nothing but an extension of URS. Anybody who knows how to do an URS or who has an excess of hand-on-eye moment in the optics of the lower tract can excel in this particular scene. Now you see the difference. You are using a natural orifice. You are using a natural passage. But this has been only possible because of the miniaturization of the equipment, the digitalization, and the techniques that have come in the last decade or so. So you can see how RIS is now taking care of the stones right in the upper tract, which was not thought of 10-15 years back. Thank you.
Okay, sir. So thank you for the comment. So this stone is in the middle calyx. So if I can even take this stone with a basket and push it in the upper calyx. Upper calyx here, but here I can do it with this easily because there is no bend and the laser fiber will go. The laser which we are using today here is an intracardiac, it's thulium laser. So it is thulium fiber. So it's a super thulium fiber laser.
This is a 60 watt laser or the 35 watt?
It's a 60 watts, sir.
Okay. Do
So
you
this-
really need a 60 watt laser for this? stone?
So this company usually offers 3 models, 35 watts, 60 watts and 120 watt. I could
120
use
watts not available in India.
35, 60 and 120. This company is making, there are 3 models. And this is also the contract manufacturer for Olympus thulium fiber laser for USA and Europe. So I shall be using thinnest fiber, that is 150 microns. Once we have what we have we have a 35 holmium from the Carl stores and the fibers are 250 above. So from here thulium, the advantage is that you have the fiber which is less than 250. So 150 micron fiber, it goes easily and your scope, it doesn't, even if you have a lower calyx, it will bend, your scope will bend and the fiber will go easily. So that is the advantage. So we have 2 programs for this thing. Simultaneously machine, the dusting versus fragmentation and dusting versus fine dusting. Fine dusting versus fragmentation. So the machine has a dual foot pedal and I can switch the program by foot pedal only. So there are 2 options for me here. So there are 2 options. Either I can do a fragmentation, get a good piece and take them out with a basket. Or I can do a fine dusting.
I think, Dr. Sajad, the kind of stone which we are seeing here, I think the dusting is a better option.
Yeah, see, what is happening, there are...
You'll be wasting time on.
No, there are, exactly. So there are 2 options for me. Either I do I just go and fragment it with the pieces and take the all pieces out, or I do a dusting. So the choice is yours. So what should I do?
Dusting.
Okay, fine.
Dr. Sajad, may I ask you a small question? Now, with the arrival of the thulium energy system, does that have any advantage stone-wise with the traditional holmium? Yes or no?
Sir?
With the arrival of thulium in the recent past, does it have any advantage over the stone management, energy-wise, over traditional holmium laser? That is my question.
Conversion. Sir, what is happening, holmium, the dusting part is very good with this thulium, dusting. And you can use it in the kidney because the space is very big. So there is no question of injuring the renal parenchyma or anything else. But using in ureter, you have to be very, very cautious because if it causes more charring than the holmium.
Okay.
So holmium should be used in the upper ureter or the ureteric stones, and thulium should be, what I recommend is in the kidney stones only.
Okay.
Dusting.
Thank you.
What are the settings? What are your settings on the laser?
बता दिखा देगा इनको settings दिखाओ इनको बता
Can you tell us the setting on the laser?
0.20 joule and 50 hertz frequency for dusting, sir.
Yeah. With this volume you can
Total
go,
output is 10 watts.
right. With this you can go to very high frequency with this laser.
कौन सा है यार
With the volume laser. We have been using it for 1.5 years now.
So I will be starting.
Professor Khan,
So you
would
can
you
see-
elaborate on this point?
There are
Whether thulium is better stone management wise or?
There are 2 big advantages with the thulium fiber. One is that the dusting particle size is very low, energy production inside the system is less, and dusting time is very less. We can do the process in a smaller time as compared to holmium. And the energy density what we are using as far as the same holmium fiber is, it's
So you
very
can see
low.
how beautifully this is the dusting is taking place. So you have to be very careful once for the youngsters or the beginners. You are doing this thing, you have to be very careful about the movements, respiratory movements of the patient. So you have to be very careful, inspiration and expiration. So you have to also hold your own breath, like inspiration and expiration.
Can you enlarge the operative picture? They are just showing the suction beaker. We don't want to see that.
Good morning, sir. This is Dr. Imran. Sir, is patient under general anesthesia or spinal anesthesia?
Under GA.
Under GA. Yes. Okay.
No, his question is, can it be done under spinal anesthesia? Because you see,
Movements.
yeah, can we have the anesthetist and ask him if he could do it under spinal anesthesia? Dr. Ruxana is there.
Are we audible?
Yeah, Dr. Arshi is and Dr.
Can Dr.
Kumara is there. So you can see
Yeah, we can
there's
see
a
it
fine dusting
moving
and this dust is being sucked.
by the sheet.
So this dust is being sucked. So you have a control of the suction also with your assistant.
So what is the source of irrigation? Is it straight from a bottle or using a pathfinder for it?
So you have to be very careful about the inspiration and expiration. So you can tell the anesthetist if you are not comfortable to just decrease the tidal volume.
Sir? So this is Dr. Imran here. Sir, how are you using the irrigation? Is it a pathfinder you are using or just a pump, irrigation pump?
Movement ज़्यादा हो रही है.
Sir, are we audible to you there? Imran sir is asking some questions, sir.
हाँ बोल. Yes, I am audible.
So what is the source of irrigation? It's
So this you can see there's a lot of movements, respiratory movements which is going on, and it's not helping me because if I touch, I can touch it to the mucosa. So I have to be very careful. मैं ऐसे बनाऊं मुझसे बता
Actually, we can do it. The spinal cord thing is that we should not be able to hold the ventilation. So diaphragmatic movement would be there.
Hello,
Yes, sir.
Yes, sir.
am I audible?
Yes,
Yeah,
sir.
yeah, we can hear
Yeah,
you.
the anesthetist stating that you can do it in a spinal anesthesia, but the only problem is the respiratory rates.
Yeah.
Because you cannot control. Here you can control with the ventilation. And especially when there isn't diverticular stones, they are very difficult, where you have a very small space.
Yeah,
At that time, it's very difficult.
my anesthetist love to do it in spinal. They
Yeah,
give
they
us spinal and they're out of the OT.
Short procedures can be done, but spinal would be slightly difficult, especially in here. Because a second thing, once the irrigation is going on, so there is always chance that there is a patient will feel the pain. CRM करता हूँ अपने पास.
Golden card.
Then you have to be really skilled to control the movement.
So this is, see you can, and we are sucking this dust. You cannot see anywhere this dust. Just see, so this is all coming through the,
You have
So-
the privilege of using
see all this section is coming, all this dust is coming through the section.
Dr. Sajad,
Yes, sir.
you have the privilege to use this suction sheet. It's not freely available.
Yeah.
And yeah, it's not freely available in the market. And everybody cannot afford it, especially in the private sector.
Yeah. It has
When
it is
nowadays
a
we
price
get a
of,
meager amount.
yeah, it is a price of 13,500. But we have the luxury of having a golden card, so we can use it for the patient's benefit.
फिर के फिर गोल्डन कार्ड पर बात आ गई।
तो हम भी गोल्डन गाड़ी मिलता है उसको क्या 30,000 31,000
अगले साल वेट करो, मोदी जब दोबारा आएंगे, गोल्डन कार्ड यहाँ से हट जाएगा। ये मेरी भविष्यवाणी है।
नहीं
It will be for- It will be for-
मूवमेंट ज्यादा कसम पेशेंट लाइट हो गया
Here, in order to lure the people, he left it for everybody.
ठीक 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 ठीक
And the more beneficiaries are those
पेशेंट लाइट है
who can easily afford.
क्या एडवाइस दिए होता है
Is one of the advisors? मुनीर की हालत है ना थोड़ा सा।
वेट भी इसका लिखा दीजिए
मैंने कोई नहीं कराया मैंने तो समय बढ़ाया है इसका। मैंने घट स्पैंड करवाया था, अब घटाया किसने? मैंने तो 60 से नीचे बंद ही नहीं किया।
था गॉस था पटा फाइब्रस लॉट ऑफ मोमेंट्स yeah so any questions so I can answer
We can see the dusting going on very well, Dr. Sajad. And
in the end when you will break the stone into fragments, they'll form many fragments.
so I have turned it upside down
Right.
so now I will go from here again and see to make it more thinner. Core is, you can see there is a hard core here. The first one, the anterior surface was slightly softer. Now here, this is a hard one. So there is, no. It's enough.
42.
It's enough.
do you complete this procedure, Dr. Sajad, with the double J stent at the end of the day?
Yes, sir.
Always?
Always. I am always a very safe surgeon. I don't want to take any chances. I always stent the patients before and after.
And leave it
So-
and remove it after 3 weeks?
Yeah, 2 weeks. Yeah.
2 weeks.
2 weeks. If you see there's a lot of fragmentation or dusting with the stem, then I will remove it at the end of the 4 weeks. But usually we go for the 2 weeks only. 2 weeks prepare, 2 weeks back. What we have seen, if we stent the patients after 1 day, 3 days, 5 days, 7 days, 14 days, 1 month, 1.5 months, 2 months, we have seen the best period is 2 weeks. Where you will not get any complications, any problems. If you keep a stent for more than a month or 1.5 months, once you remove the stent, the orifice is so much of edematous that you will not be able to see the ureteric orifice again. So in those cases, what you have to be very sure that you first, before removing the stent, you put a guide wire. So you are in the ureter, otherwise you will lose the track. So we have seen it with many patients. So this is the experience what we are getting, and that is the way to go forward.
Dr. Sajad,
Yeah.
I have a question, at what level you will prefer keeping your access sheath, the upper end?
Yeah, see, a very good question. So I usually, it depends upon where the stone is.
Okay.
So if your stone is in the pelvis,
Okay.
because you don't need a more bending of the scope.
Uh-huh.
So you can keep it in just at the PUJ or the upper ureter.
Okay.
But if it is in the calyces where you need a deflection,
Uh-huh.
then your scope has to be somewhere up, just in the middle of the ureter. Because the scope will not bend
Right.
if your SSH is going there.
Right.
Only 3 instruments.
Thank you, sir. And now we'll be shifting to OT2 for another case that will be done simultaneously by Professor Mallikarjuna, sir.
Yeah, fine.
He is a managing director and chief consultant urologist, Asian Institute of Nephrology and Urology, Hyderabad, India. Vice President, National Board of Examinations. He has been past president of Urological Society of India, and he is pioneer in laparoscopic and robotic urology. Faculty and organizer of numerous live operative workshops throughout India. Passionate, and it's a well-known fact, he's a passionate teacher and mentor for many urologists. And his special interest in laparoscopy and robotic urology and uro-oncology. Now we'll be going back to OT2 and they will be telling us
और कोई
about the
इंस्ट्रूमेंट है
case.
फोर्सेप्स का ये ठीक
Can we shift to OT2?
दूसरा वाला ले लो